Welcome everyone to another episode of the MD Clone Talk Data Podcast.
You are listening to the MD Clone Talk Data Podcast, the show that uncovers healthcare insights, technology innovation, and discovers new ways to understand data possibilities. We bring together industry leaders, customers, and innovators to drive the future of care delivery. Let's talk data.
So on today's episode, we're traveling north of the border, or at least as a Chicagoan, that's how I think of it. And we're going to be discussing healthcare in Canada. But I think in a way, we're going to be discussing really healthcare globally. We're going to understand really how to use ideas, technologies, data to improve quality, improve care delivered to patients. And I'm really excited to have Dr. Alan Forrester join us. Dr. Forrester is the VP for Quality and Innovation at the Ottawa Hospital. And I spent quite a bit of time with Alan, and I can tell you that his mind races in many ways to a lot of these ideas and is really passionate about these topics. So really excited to dive into that with you today. So welcome.
Thank you, Daniel.
So when we first met and we're having some of those conversations, we dove right into some of the key challenges facing healthcare in Canada and facing patients. So can you talk a little bit around some of what your key challenges are in Canada, and maybe those extend quite a bit globally as well?
Yeah, I think these are pretty universal challenges. First of all, if you did a poll of Canadians what they felt were the biggest challenges in healthcare, it really revolves around access to care, whether that be access to a primary care physician for advice and support around prevention care, or around how to resolve some acute problem, or whether it's access to a specialist, access to imaging, or access to procedures. I would say those tend to be the major concerns. We have universal health care, so everyone's covered. But that does leave some constraints at the other end where sometimes people have to wait.
All right. So we're all about data on this podcast, perhaps, but it's also in the background of MD Clone. But it extends beyond data, extends to really information that can help us understand how to treat patients in a safer way, in a more efficient way, in a more effective way. So at the challenge, you talk about access. How can access to that information that we talk about help some of these challenges?
Well, in order to improve a system, you have to understand the system, and the system itself. There's a lot to understanding a system. Fundamentally, it's data describing what is actually going on in the system. And typically we have a big blockage in access to data. For a variety of reasons. I think most people know about, the privacy rules, the technology challenges, but that really limits our ability to understand the system. And typically what happens then is people argue as to what is the cause of the blockages or the access challenges without really the data to support their arguments. And that becomes a big challenge, whether there's a key constraint, like a blockage of that we just don't have enough of a particular type of person or role, or whether we're just applying it incorrectly at the wrong place at the wrong time. We can never really get to that answer, and therefore we can't invest wisely to reduce the problem. And if we can't do that, then we're left to arguing about what people's opinions are.
I want to go perhaps to almost to the patient room a little bit, because you're a physician, you've practiced, you've seen your fair share of patients over your career. How do you think access to that information, to that data, you can give an example or a thought around how that would have helped you as a clinician?
Well, I'll give a simple example. I did do general internal medicine. That was my role and I did hospital consultation medicine. So oftentimes people in the emergency department, I would get referrals from the emergency department. We would organize our shifts from 9 or 8 in the morning till 5 p.m. at night. And then we would hand over to the next person. What typically happens when people, if you look at the data though, the referrals are happening between midday and 10 or 11 at night. And that's when we get sort of 80-90% of our referrals from the emergency department. So, why do we have our shifts staggered from 8 to 5 and then onward? Why don't we stagger our shifts from, midday to 11 at night and then have maybe an overnight coverage? So just a very simple thing. I mean, it's a time of day of when the referrals are happening can have a great impact on how we organize our day and how we have our, how efficient we might be. The other thing is based on the number of patients showing up. Maybe we should have 2 people on or 3 people on during those time periods. We could look at the variation in response time and how long it takes to do the referrals. We could look at the types of patients that are coming in, the types of services they require, the types of investigations, and we could really drive quality improvement to make those services a little bit more aligned with when the demand is occurring and with the demand that's required. And that could drive better services for the patient, lower costs, more timely service, better outcomes ultimately.
So in that sort of frame, that context, you lead quality at the hospital. You wear that hat a lot. How would you tackle? I mean, how do you tackle that problem? What are the people that you throw at that on your team? You have some very talented people on your team that we've worked with at MD Clone, and what does that process look like today?
Well, I think first of all, you have to look across the organization. Like I have people who report to me, my analytics team and my quality team, but really my team is the Ottawa Hospital, right? So we have an amazing executive team, an amazing medical staff, medical leadership, and really it is all of that. That's where we drive quality and how we create quality. Our CEO has focused very much on executing in terms of high quality of care. Our purpose, our vision is to provide care as if we were providing care for a loved one. So really that inspires people. The focus, has to be a bit broader than overall patient experience, but we do focus on that healthcare quadruple aim. As an executive team, we've selected the quadruple aim as an overarching strategy for achieving success. Once you have measures of success at the corporate level and guiding principles and values, working with the analytics team to help understand why we might see gaps between our desired performance and our actual performance, then we start to think about how do we engage our clinicians. We've built structures within our hospital that have a relationship between hospital management and administrative staff, as well as our physician staff. And we really rely on that partnership, but they can only be supported through that data. And, why would they get engaged if there wasn't data demonstrating there was a problem? Once we've identified the problem, it flips over to our quality improvement team. And, we set targets as a leadership, but we also work closely with our teams to understand how we drive improvements in our quality. We have a formal methodology for improving quality that we use. And again, data is at the core of it. Without having the data, we can't do anything. But those quality improvement folks really work closely with frontline clinicians, frontline nurses, frontline pharmacists to drive those improvements that we're looking for.
So let's maybe put the innovation hat on a bit and go to another side of the ecosystem. At least in my head, I'm thinking them on 2 sides, because there's sort of the rest of the world out there who has potentially a lot of interest and a lot of capability to help this process that doesn't sit inside the hospital, doesn't sit in with affiliated research organizations. I'm thinking about entrepreneurs and startup companies and tech companies and life science companies that are out there trying to solve a lot of the same challenges that you see every day inside the hospital. How can you work more efficiently, more effectively, and leverage that ultimately for better outcomes?
Well, I think first of all, there's a culture issue that goes on. And I don't think this is necessarily about data. I think it's also about sort of a willingness to consider that outside the hospital or outside the health system, there are people who have expertise that can be used to drive benefit. And I think that openness to the outside is really critical. First of all, and that's a big shift, right? Like healthcare has been a pretty closed box and closed system. And so we have to kind of get over that. There are ways to make that happen, I believe. And we're trying to work very closely by creating the rules and the processes and the procedures to help facilitate, structured interactions, which protect patient privacy, protect patient safety, protect patient interest. Engaging patients in this process is part of that. It's also about finding resources to help support it. Hospitals are supported are paid to do clinical care. So we have to find alternative ways to build this kind of capability. But let's assume we get over the processes and the funding. Then it's about experimenting. And then it comes down to data again, right? It comes down to data that shows the value. Without the data that shows value, there's no point in doing the evaluation. So again, and fundamentally, we need the data anyway, like for the health system. So it's really a small little part to make it available for the innovation ecosystem and support those startups to help demonstrate the value of their product. And I think fundamentally, what blocks innovation more than anything else, or blocks the adoption of new technologies more than anything else, is the failure to show benefit and value. Once you show value, truly show it, demonstrate it in a way that matters to the customer, then the organizations are foolish not to pursue it.
So with all of this, I think one of the newer buzzwords out there is a learning health system, this concept of a learning health system. And I think that has to do, my understanding of it at least, is it has to do with, in many ways, bringing all this people and all this knowledge together to grow sort of in one direction. But what does that mean to you? What's a learning health system?
You described it very well. I'm not sure I can add much, but just in my words, fundamentally, we have to create incentives and opportunities for individuals to learn. Individuals can learn in their practice, right? In what they do. And we have, we all have a responsibility. We all have a background knowledge, but over our lifetimes, we learn. We learn from experience. Only when people are working with you to give you the feedback in a formal way, when that formal feedback is aligned with a discipline of what you're trying to accomplish. And some people have talked about the sort of three phases of learning when we're trying to build a learning system. One is translating data to knowledge, practice to data. So practice to data is really the instrumentation. How are we getting data out of the real world into a machine? So practice to data. The second is data to knowledge. This is a bit harder because now you're taking data that's which is really describing your experience, what's happened in the real world, but you're combining it with what people know. So you have to build up communities of practice. You have to build in formal methods for bringing in research and evidence from elsewhere. And you have to build in mechanisms by which people can reflect on that information and use it to come up with decisions, to act. And then the third part is the knowledge to action, which is, that is truly the hardest part, changing how we do things based on knowledge. Because, ultimately people have different interpretations of what it is we have to work on. People have different incentives. People have different capabilities for change. And so there's oftentimes a challenge in making that knowledge to action happen. But of course, then it closes the loop because that knowledge to action now results in new changes in practice, which then you go back to practice to data. And so to me, that's the learning system. Only when you combine that with goals. You have to have organizational goals. And actually, those ideally are personal goals. So if you have personal goals that line up with the organizational goals, and then you build in this flywheel effect of practice to data to knowledge, and knowledge to action at both the micro level of an individual, but also the macro level of an organization, then you really start to see enhanced learning and enhanced achievement of goals. And I think actually fulfillment of the people working in the system as well.
So it's maybe on that fulfillment point, but we'll come back to that in a moment. But I have to say, you basically described MD clone atoms as a concept there, in your own words and in the own processes that you see it. But perhaps there's one more. One of the parts of MD clone to add at the end before the cycle starts to repeat itself, or maybe after the cycle repeats itself and starts to really get flowing, which is our ability to share that. So what are your thoughts around, okay, we've discovered something, we've enabled that discovery to actually move into some actionable place within the health system. we maybe have measured that. We've in some way understood that that is a meaningful change. What happens next? How do you collaborate with that knowledge?
Well, and that's where we're too slow right now. And that's, again, where I would say Adams is a fundamental shift in thinking with that ability to share. And, we're stuck in healthcare right now. People have described it as a bit of a cottage industry. Even still with all the integration that's going on in health systems and digitization with the electronic medical records, there still is a lot of degrees of freedom and a huge amount of variation. And we still leave things to individual practitioners more than probably most industries. And so the idea that we have this cottage industry effect is driven largely because we don't have data demonstrating what the benefits are, nor do we have the real world evidence of the effects of interventions to drive change. And so this opportunity to share best practice, share the impact of implementations of change, using a formal data structure and measurement process that is replicable across countries, across other types of jurisdictions, languages, is unbelievable, really, quite frankly. This is what will take us to that that opportunity where we now start to see that move away from a cottage industry to one where we're seeing demonstrated value. That is better outcomes at lower cost, because we're very confident as to the way in which we remove waste and add value, add benefit.
Do you think your teams are ready to not just share out, but sort of accept in, learn from others? How would that work? How do you see that happening with another health system?
Well, I see that there's an opportunity within an institution. We've been talking about this Adams Center concept, where you have, at the core, you have a sort of a system administrator to help and sort of change expertise, which is really helping coordinate activity. But really, what's driving it are what I'll call the spokes, or the centers of excellence within service lines. That could be a cardiology unit or a nephrology unit, or it could be a cancer surgery group. And really, those groups are really being driven using, again, the platform. They're going to want to collaborate with cancer researchers or cardiologists or nephrologists. They're not going to want to collaborate necessarily with each other, right? So the nephrologists are going to want to talk to nephrologists in other centers. And if our kidney program has identified a problem, they've acted on that, they've measured an impact, they definitely want to share that. And they're going to want to share that with other nephrologists and other kidney programs. Ultimately, the vehicle to do that through the global network is really exciting. We have right now, the only vehicle for that to happen is really through publications or scientific meetings. Now, it can be done with a few clicks of a mouse. And the more hospitals that have that same structure and the same capability of talking to each other through this web of webs, I think is really cool. Again, it gets to that fundamental paradigm shift now. And the more hospitals and health systems that are using MD Clone, and the more that have that framework of the Adams Center, where we have these webs, the more we'll be able to drive those changes. And once there's a sort of critical mass of that, then we'll really start to see change happening. And I think there's no real alternatives for this to happen right now. The people have been trying for 30, 40 years to build these kinds of learning networks. And, they keep using the same basic framework, where we've all got to dump our data into a common place, as opposed to working locally to drive value, but working locally in a way that's actually so consistent enough and flexible enough that it'll allow us to share with others.
Okay, so one of the key parts of sharing, there's knowledge for sure, and there's processes that have been developed over this sort of cycle of iterating on data. One of the key components, though, we've talked a bit about privacy, is maintaining that privacy and having data that you trust and that you feel like patients can trust, that can be shared. I want to hear a little bit your thoughts on this sort of initially maybe crazy idea of synthetic data. what did you think about it when you first heard about it? How have you come to think about synthetic data as a mechanism for that broader sharing and collaboration?
First of all, when I first heard about it, I was excited. I saw immediately that the potential was there to transform how we do things. Synthetic data, can be constructed to look like real data. And, I'd been using that approach in my research and with some of our work in a kind of what I'll call a dumb way, right? Like just to help with when you're working with big data sets, it helps you to do things. But at the same time, it's kind of, that was, while it was okay, it really wasn't very effective, right? Because it didn't give you insight. It just helped you build your prototypes. Once you can see the potential of actually generating synthetic data, which is which behaves like the real data, like the real patient data, and therefore the insights are accurate. Then it becomes this huge benefit, and it quickly becomes this kind of very academic tool to something that's very practical and usable, especially the way MD Clone's done it, where you can generate the synthetic data on the fly for the specific use case, for the specific sample size, for your specific patient population. Ultimately, it just makes it an incredibly powerful tool to do something that people have always used, but it just is. It now becomes, it can really quickly accelerate change because you don't have to stand in line or wait for that real data.
Yeah. What does that line look like today?
To get real data?
To get data in general.
It's a long line.
Yeah.
It's a long line with a lot of channels.
Yeah.
We had a pretty solid data warehouse in Ottawa up until 2019, and we implemented a new electronic medical record at that time. When we did that, it kind of blew up our electronic medical record. Before 2019, we had a reasonable approach for getting data to people, but it was still very frustrating for our users. Like if you really want to think about it, our users were very frustrated with us. They couldn't get access to data because if they wanted it, it took 3 to 6 months or even longer to get it. Now we had to accelerate, like if the chief operating officer asked for something, or if the head of medicine asked for something, they would get it and they would get jumped to the front line. But that meant there was a lot of people who were pretty frustrated. When we got the new EMR, it kind of blew everything up even worse. It was just way more data, way more complexity, way more like lack of understanding of what the data are, where it is, where they are. And so that just made the problem like, we were sort of under the impression that by getting the new EMR would make it all better. But in fact, it made the existing problem sort of many-fold worse. And that's for internal data. Like if you want to get data from external, like from other hospitals, other health systems, other sources of information, health plan data, medication data, data from other healthcare sectors, social services, like forget it. Being able to, then have to link that data, it becomes almost impossible to solve that problem. And so, as I said, the lineups are long and the channels are many. So it basically blocks all of those great things that we've just talked about.
So there's the ability to go global, and we talked a bit about that. But that a lot of those sources of data, they exist in Ottawa, or certainly in Ontario, certainly in Canada. I know you have a vision around a sort of Canadian hub centered in Ottawa that could be a source of rich information, but also people, processes that could engage the sort of ecosystem. Tell me a little bit that vision and some of your thoughts there.
Yeah, and I want to correct you a little bit, because the centering it in Ottawa, what I see is it's not really a hub and spoke from Ottawa. It's really a network of hubs across Canada. And as you said, one of the great things about MD Clone is individual institutions have their data, and can manage it and look after it and use it to the extent that they want to. But at the same time, they can collaborate across borders and can collaborate across jurisdictions without any investment required. They don't have to build a central data repository between hospitals or between provinces, because immediately, if each jurisdiction has MD Clone, they can start sharing information, synthetic data files immediately. And it just takes a willingness to work together, as opposed to the willingness plus all of the technical and ethical and legal issues that are required. So we've done some neat work with folks in the United States and also with people in Sheba, different institutions, and I'll tell you, it was eye-opening how quickly we could generate insight. And so why couldn't we do that in the country where I live, which is supporting healthcare? It's part of our purpose as a government is to help support its people through healthcare. So why should we not do this? And I think the reason why we haven't been doing it is because it's been difficult and costly. And as I said, I think we're finding this pathway is going to be much, much quicker. But I would say it's not really with us at the center. It would be perhaps us experiencing first and then perhaps helping other people understand how to do it. But I would want it to be all equals to drive that forward.
So I think we keep going on forever here. As I said, mine's race here. But I would also say in that sort of that context of maybe it's a network of hubs around the world, but you're definitely one of those key hubs. And I want to invite people to see what you're doing. I've gotten to visit a number of times and clearly spend quite a bit of time with you. So I would almost want to visit our audience to spend some time with you and really dive into many of these topics much more. We do have some resources available on the MD Clone website and some other places that we'll ultimately be able to share. But I hope we can keep this conversation going in other ways. I know it's going to be through more collaboration, more projects, research in nature, operations in nature, innovation, collaboration with third parties and the like. So excited for more to come. Thank you very much for joining us today.
Well, thank you for having me. And I'm very welcoming. So anyone who wants to come visit, I will gladly make our place available.
Great. So thank you again. And we'll see everyone on the next MD Clone Talk Data podcast.